Hi, everyone. Thank you for joining our webinar, Your Decisions Matter. This is presented by experts from Carilion Clinic Hospice. Today, we have Dr. Brian Unwin, Chief of Carilion Clinic Geriatrics, Hospice, and Palliative Medicine, joining us. We also have Lisa Sprinkle. She is Vice President of Carilion Clinic Home Care and Hospice. And then we have Nicole Bailey Bedsall, Licensed Clinical Social Worker for Carilion Clinic Home Health. I'm Karen McNew-McGuire, Senior Communications and Marketing Consultant at Carilion Clinic, and I'll serve as our moderator for the day. We're looking forward to any questions you have. I'll tell you how we're going to field those in a moment. Today, you'll learn about the values, the wishes, and goals that emerge during an emergency or at the end of life, things that we often can't specifically plan for, but there are plans we can put in place so if that happens, we are prepared. That's what we're talking about today, being prepared for those moments, how to honor those wishes, how to translate them into a plan of care that makes sense for everyone, you and your loved ones, the things that you deem most essential to decision making in those emergent times. We're going to start with a brief introduction by Dr. Unwin, followed by a question and answer panel discussion. If you have those questions, just pop them in the chat box whenever they pop into your mind, and then we'll get to those at the end of our presentation. Dr. Unwin, take it away.
Thank you. Honored to be here today, and I hope you're hearing me. This is story time, and I'm going to start and tell you a story about my parents. Chester and Margaret Unwin married Valentine's Day, 1957. My dad was a farm boy from southeastern Colorado, went to World War II as a truck driver and military policeman, came back from that, left the farm, married, remarried, and met my mom. And my mom, born and raised in New York City, never finished high school, joined the Army as a Women's Army Corps private. She finished the war, left the Women's Army Corps, married, divorced, remarried, married my father. And then they actually met at a place called the Dewdrop Inn in Pueblo, Colorado. It's still around, interesting little bar. They had two boys, myself and my brother, Jason. Jason and I both were ROTC, went to ROTC in college. Jason was a field artillery officer and then went into corrections, and I became a physician. And my parents began their late life decline in the mid 90s. My brother is finishing up his military service. I'm 10 years into being a doctor. Both my parents had bad COPD. My mom had dementia, and she became very difficult to work with. Over time, things got really difficult to manage at home for my brother and my father with her, and she and my parents and I elected for nursing home care. They had a lot of trouble, but the good thing out of that experience is that before their decline, we had family challenges with my grandparents. One grandmother dying from dementia and frailty, another grandmother dying from lung cancer, one grandfather dying from Parkinson's disease, another grandfather dying from complications of diabetes. And the important thing out of those experiences as we applied to my parents is that we had family discussions, and we knew what was going on with my grandparents, and our parents shared with my brother and I what was going on with them. And my brother and I had very clear understanding about what types of treatments and things my parents would find acceptable in their late life care. And so, for example, being in a nursing home for my mother was an acceptable thing. Not what we wanted, not what we dreamt of doing, but that was what worked for my family at that time. And it was those experiences with my grandparents, my parents, or military experiences where my brother and I always had to have our will and power of attorney always ready to go in case of deployment, and not just the documents, but the conversations with my wife and children about what if things go south during a deployment. My parents decided that they did not want heroics. They did not want CPR in late life. My father was very clear that he did not want any, very colorfully said what types of treatments he did not want in his care. And those conversations allowed for clarity. It allowed for sharing of roles between my brother and I. It allowed for collaboration and not conflict. And both my parents passed in 2006. And this is the last photo that I have of my dad, my brother, and I in 2006 before he died. And that conversation, those things continue now as my wife and I, as I get older, we updated our wills and we've had conversations with our children. And we're currently working with my mother-in-law and her advanced dementia. And thankfully, because we have advanced directives and we've communicated, my brother-in-laws and I and my wife have a clarity about how to care for my mother-in-law in her late life, and that prevents unnecessary suffering. And so we look forward to having this conversation with you today. Thank you for listening to my story, and we'll open it up to the panel.
Thank you, Dr. Unwin, for sharing that story to kick off this discussion that is so very important. We're going to jump into our questions for our panel to address. So we're looking forward to learning more about this topic. First, what is advanced care planning? And this one's for you, Nicole, and then explain any sort of key terms that we may not be aware of, but when it comes to starting this process, we're going to get familiar with pretty quickly.
Sure, sure. Advanced care planning really is a process in itself. I think we associate it with older age, but really at any age, a medical crisis could leave us to not be able to make our own healthcare decisions. So even if you're not sick now, making healthcare plans is an important step towards making sure you get the medical care you may or may not want. Um, it involves learning about the types of decisions that you might need to be made, considering those decisions ahead of time, and letting others know. Like Dr. Unwin and his family are doing such a great job talking to each other and going ahead and having those open conversations about what treatments would be best, and how they can respect those options. That's really what this is about, a conversation that you hope to then put into a legal document. So when we talk about an advance directive, there's two parts. There's a healthcare agent, surrogate decision maker part, and there's a living will part. So the first part of naming a healthcare decision maker would be someone who you would want to know your values and wishes, really understand what type of care you may or may not want, and then also respect that and be the one to kind of advocate for you and make sure that they know you best and really know. I think Dr. Unwin said this before: know your soul, and they're gonna treat you with the respect that you deserve by valuing and honoring what you may or may not want, because those had been expressed previously. The living will part is more of a discussion about medical treatment. So that's going to go ahead and be giving some direction to your doctors and to your family about different interventions. If you're permanently unconscious, if you could not make decisions for emergency treatment, things of that nature.
Thank you, Nicole. So talking about questions that you want to address during that advanced care planning. And then Lisa, help us understand. I mean, we have some folks, some family members don't want to talk about this. I don't want to talk about it because if I talk about it, that's going to make it real. But whether they talk about it or not, it's a real situation. What are some of those questions to discuss and approaches to use for those family members who don't want to be compliant with the process?
Those are all great points and questions, Karen. And it is natural for us to be uncomfortable talking about the process of dying because we live in a death averse society. We are fortunate in the Roanoke Valley to have an abundance of medical services available to us who are all programmed and designed to intervene and heal. And so the concept of our inability to heal the body of the disease at times can be uncomfortable. So, what I recommend for folks, and I've had to employ this with my own parents even, is not to think about advanced care planning in the context of dying, but in the context of living. What is important to me as an individual is that being free of symptoms, to Dr. Unwin's point earlier, eliminating pain and suffering. Is it important to me to have more time, regardless of how that might have to occur? So it's important to think about our own individual goals and wishes and what we value the most. Um, and it's in that context of how we live that begins to define how we wish our end of life care to look. As Dr. Unwin said, healthcare settings can sometimes be chaotic. And so it's important that we have a plan, knowing that even in the process of planning, chaos can interfere and lead to miscommunication. So everything that we've said today in terms of having first of all, the introspective thought that then becomes translated into conversation with those we love and who are going to be making those decisions on our behalf. And then going a step further to translate that into a legal document. That is the process of advanced care planning. There's other questions that we may want to contemplate. If I am dealing with a new diagnosis that may be life-limiting or serious or become very complex, as Dr. Unwin's parents were dealing with COPD, then other questions that I want to ask during the advanced care planning process is, what does this mean? What disease trajectory should I anticipate? What does the advancement of my illness look like? How much do I want to know about that? And how much do I want to share with my family about that? So those are contemplative questions that may come into your mind as you receive a diagnosis of yourself or a loved one close to you. But again, the important thing is to think about what we as individuals value most in our life and interweave that into our advanced care planning conversations with those we love and in the documents that we eventually execute.
Thanks for putting it in a way that is easy to understand, Lisa. So good to hear all of that. To Nicole about some of the terms. And so when you get into this process, you may hear the term healthcare agent. So we want to talk about what is a healthcare agent and who can be your healthcare agent. Dr. Unwin, help us out with that one.
Really, anyone can be your healthcare agent. And ideally, again, like I think Nicole said, it's someone that kind of knows your soul, someone who knows your way of thinking. And importantly, it has to be someone you've talked to. Naming an agent and then your agent not knowing what your wishes and desires are is kind of backward. It doesn't help the process. And so it should be someone who knows your soul, you've talked with, and someone that supports you in your way of thinking and your approach. And so typically that can fall on family, but often it doesn't. And there's no right or wrong with that, no judgment with that. But the key thing then is if it is someone, especially out of family, or I'll just say the word surprising, then it's really important that that surrogate is named legally in a document. And I would also argue that it would be important for the family that is not named to be aware of the choice and the reasons for those choices. And again, it's to reduce conflict, it's to reduce that angst, it's to reduce the unnecessary suffering that can occur because of confusion or doubt and family arguments and things like that.
And that brings me to, we have a question in our chat from one of our attendees, and it's a little bit different, but sort of along the lines of staying in touch with the wants and needs of the loved one who you are going to be the agent for. So our question is, can you, and if you don't have the answer to this right away, we can follow up in chat or what have you with resources. So the question is, can you name a good organization or online resource that updates current policies for U.S. states regarding physician-assisted end-of-life or right-to-die decisions? Our attendee says, I don't want my children going to the extent I've had to for parental decline. This is a very different situation that most advanced medical directives cover.
I'll start with that. So I'm doing a Google search as we look here, so I get some of the facts correct. But in 2023, earlier in the year, one of the congressional sessions, a bill was forwarded to allow for medical aid in dying in Virginia, and it was not approved. I don't have really an update beyond that unless Lisa or Nicole do. In terms of advice or position statements and learning more about medical aid in dying, I think turning to organizations such as the National Hospice and Palliative Care Organization is a really good resource, and that would be nhpco.org. I'll put that in a message here. And it has a position statement from hospice and palliative medicine organizations about medical aid in dying. I think in our situation where we do not have a medical aid in dying program in our state, I think it's then important to make sure that we have advanced directives in place and those conversations in place. And then if a advanced illness begins to manifest and it becomes severe, then you're implementing tools like do not resuscitate orders or Virginia physician orders for scope of treatment. And I think also just to say it's reasonable to keep an eye out and watch the news in terms and be involved with the discussions about medical aid in dying, because it is an important topic, and it's a topic that can be fraught with misunderstanding. And so it is it's good to have those conversations with your family as well as your provider. Lisa and Nicole?
If I could just chime in, I think that's a very insightful question. And I applaud our attendee for thinking through that, because what I hear is that there is such a love for their children that they don't want them to be burdened by the physical demands of caregiving, perhaps. And so I have tremendous respect for that. And I think that underscores one of the important things we're talking about, and that is that planning can actually be a gift for the people that we love the most. That clarity, that confidence in knowing that what I am doing on behalf of my mom and dad are the things they want me to do. I would challenge us sometimes to question what we're afraid of. And so, are we interested in additional supports through the process of dying because we're afraid of being in pain, or we're afraid of having some breathing challenges? So understanding those underlying fears also helps us inform a plan. And I would just use this opportunity to say that there are trained professionals, even though we don't have medical aid in dying available to us in Virginia. Hospice is a word that people are afraid of, but they are the experts in alleviating suffering. Just like we go to cardiology when we have a special need of the heart, or we go to neurology when we have a special need of the brain, we can look to our palliative medicine and our hospice providers who specialize in delivering comfortable peaceful, respectful care. And so I just didn't want to lose that opportunity to provide some reassurance that though a formal medical aid in dying process is not available, and I want to be clear, hospice doesn't hasten death, but oftentimes when pain and symptoms are controlled, nature takes its course and delivers that in a very dignified and respectful way. And I just wanted to acknowledge that. So thank you for that great question.
Yeah, I just to add into that, Lisa, just wonderful responses. I think about, how many times it's such a gift to do what I do. I get to go into people's homes and really get to meet their families and be a part of stressful times, but also seeing your loved ones come together to help others and help fill in when needed. It's beautiful, and I absolutely love what I do. And there are times when I do these conversations, advanced care planning conversations, and at the end of it, the daughter's like, "Gosh, I've been worried because I had no idea what you wanted, mom." And it's like this aha moment that the patient and the relative, daughter, whoever it may be, really both were stressed about it, but didn't know how to talk about it because there is a stigma at times. We don't want to talk about things because we don't want it to become true. Does that make sense? If you bring it into the world, then maybe a sudden illness will happen. Maybe an accident will happen. But the truth is, it's a complete gift for us to be able to still be in control of things we may not have any control of at any time. Life is unpredictable, and a gift to our families, or whoever we pick as our surrogates or decision makers, to be the ones that have to represent us, and them have peace with knowing they're doing right by what you wanted. So just want to add that in.
We did have a follow-up comment from our attendee suggesting and reiterating that the question came from it being about the body continuing on and on when there's so little left of the person. So not pain or physical issues, but just hope I'm interpreting this correctly, prolonging what seems to be the inevitable. I think that was one of the impetus for asking the original question.
Mhm.
So we appreciate that wonderful conversation that we were able to have, some clarity to achieve on that topic. And we will move on to documenting some of those decisions. Nicole, help us understand how we should document the things that we want.
Sure. So a lot of times I hear, do I need an attorney to do a healthcare directive? And you don't. The Virginia State Bar has a wonderful document called a Virginia Advance Directive, which can be done with two witness signatures. And that goes over what we talked about, choosing a healthcare agent, and then also going and documenting your living will wishes. Um, Two witness signatures, it is a legal document. Then you would provide that with your medical professionals and your family, and you at least have that part taken care of. There are other documents that, just in planning in general, are always good. Financial, durable power of attorney, just estate planning, things like that. That's kind of beyond the scope of what we can do here in healthcare, but also conversations to be had when you're talking about end of life planning. But today I really want to focus on, yes, the document's important, and it is, and I hope everyone will leave. And if you've done it, that's awesome. If you feel like you need to revisit it, that's great. But I really feel like the conversations are very, very important, and maybe the most important, because even if you do the document, but you never tell your friend down the street that you picked them to be on it, they may read what you checked on a box. They may see a check box, but they didn't have a discussion with you. They didn't talk about what you value most, what quality of life means to you, what are your fears, what would you like to avoid, and that comes with experiences too. As we get older, we have, friends or family or people that we know that may get sick or may have an accident, and a lot of seeing it kind of helps us have some perspective about, well, gosh, I wonder if that was really stressful for them. I wonder if I could do something different. And what you can do is start talking about your wishes now. And then documenting that on a Virginia Advanced Directive would be the form that you would be using.
And this is sort of a follow-up on that note to any of our panel members. In my own personal experience with a loved one who didn't like hospitals, didn't want to go to the doctor, when needed to go to the doctor, would put it off, and then only like in that moment of extreme need. So once this person passed, her nurse practitioner explained to me that I honored her wishes and how important that is. As a family member, you may want to force your loved one to go to the hospital because you think it's right for them. But when that loved one says, no, I don't want to, and I don't feel like I need to, help us to understand the importance of setting your own personal beliefs aside in order to serve that loved one the way they want to be cared for.
I'll start because this will be a broad discussion with Lisa and Nicole. I'll say at the beginning, one of the issues that is faced in that situation is the question of, does that patient at that time have the capacity and understanding to really understand and make that choice? Where it's more of a reflex of, I don't want to go to the hospital, but the patient is suffering or has a broken bone or a major injury or something, where kind of common sense would dictate, we got to do something here. So there's a part of the question begins with the capacity of the patient to say no to that kind of thing. And then the family saying, well, yes, we're going to go, or yes, the patient has the capacity to do that. And so I'll start with that. It begins with a discernment of, does the patient really understand and appreciate what's going on? And then the family works with that from there. I think it's always best, and we can always kind of be happy with what we see in the mirror, that when we're making decisions on behalf of another person that reflect that person's way of thinking, we can sleep well at night.
If I can follow up, Dr. Unwin, you're exactly right in terms of capacity. I think one of the most enlightening conversations that I've had in my professional career was with a gentleman who had a life-limiting condition. And he was very, very clear on his own volition about his advanced care plan and what that should look like. His greatest concern was that his son did not agree with his wishes. And he had a very valid fear that at the point at which he could not speak for himself, his disease process would eventually, in all likelihood, if it ran its normal course, would render him in a position of not being able to make his own decisions. His fear was that his son might unwind his advanced care plan. I think that's a very valid fear and one that can be rectified with not only a very honest conversation, but as Nicole can share with us, we do have a document in the state of Virginia called a post form that takes that advanced care plan and translates it into a physician's order. So once performed, once the post form is completed, then even our surrogate can't unravel that form. Only the patient who executed that form can do that. And so I'll ask Nicole to explain that to us in a little bit more detail.
Yeah, that's a great point, Lisa. And I think that you see a lot of these struggles, wanting to not disappoint, quote unquote, their children by quote unquote giving up, but it's changing the thought process of that conversation, because those words aren't what the process is. That's not what advanced care planning is. That's not what making your wishes known That's not what it's about. And the post really lets us expand, and it really goes into, would you want CPR? Would you not want CPR? What medical interventions would you want? And that's, comfort care, limited interventions, full interventions. This is done with your primary care physician. This is done with your doctor. So you're going to be talking directly with your doctor about how these different medical interventions will, how they look like with your chronic illness, the trajectory of, that's a decision between a conversation between your doctor and you, and then a decision to be made. But the post form, once completed, is a physician's order. It is a portable order, and that means no one can override that. No one can change those wishes, not even if you have an advance directive. So I definitely feel like that would be a next step for anyone who is worried that their wishes of comfort measures would not be met. So that's definitely a form. And if you're interested, you just want to talk to your primary care physician.
Thank you so much. What a great explanation. I think a lot of us are learning about opportunities that we didn't know existed. We did have a couple of questions. One is the Virginia Advanced Directive available online? If so, would you share the website?
Yes.
And then also, do you use the 5 wishes document?
Yes. Love the 5 wishes document. I leave that a lot with patients and families. It's very thought provoking. Wonderful document. It really takes you through a lot of the questions that Lisa talked about earlier. What matters most? What are your fears? And kind of helps you get to really deciding what decisions would be made. And that is available. They have those in a lot of our growing facilities. We have access to those. The Virginia Advanced Directive is on the Virginia State Bar website, and we can put that in the chat. And you can print that off, again, 2 witness signatures. Post form, you have to see your doctor. That's not something that anyone can do, but that's also available.
And on that, Nicole, we had a follow-up. How long does the post form stay in effect?
Until you pass away. So if I did one today, that would be good until I updated, revoked it, or changed it. So the person has to revoke it or change it, and there's a whole process for that. So ultimately, it is as good as long as you still want it to be in existence. If you don't want it to be in existence anymore, you change your mind, you can revoke it. So that's all of these processes. They're not set in stone. I feel like people get bogged down with that. Well, what if I decide today, this is what I want, but in a month, I think that the process is really, when we become adults, we start to, it's tax season, right? So we're all doing our taxes. We're all doing these things that are planning. And advanced care planning changes with us over time. What I want now may not be what I want in 5 years, 10 years, 20. That's going to depend on my health, my age. So these conversations, they're fluid.
And would it be appropriate to think of going ahead and starting that process, no matter what state of health or age, as sort of like your rough draft for your future?
Yes.
Like you've got it started and I can make changes anytime I want.
I think that everybody should have an advance directive. I'm very passionate about that. I feel like, again, that is something that we should, and once you start it, you have that document with all your other documents, you're going to say, okay, is it time to update? And life is full of changes. People separate, people divorce, spouses pass, children pass. So again, these are documents that can change over time, but it is important for us all to have an advance directive.
I would add that our health changes over time. When you go to the doctor's office, you'll encounter a question on screening. Do you have an advance directive? Yes, I do. But then the next step is, that advance directive is 10 years old, and I didn't have lung disease then, or I didn't have Parkinson's disease then, or I didn't have cancer then, Or, and it should be a moment of reflection where you're saying to yourself, how am I different now than when I developed that advanced directive? And a lot of times people have said, yes, I have an advanced directive, and really do not know what that means. And so having the document, and having gone to a lawyer, et cetera, but then really maybe sitting down with a nurse practitioner, sitting down with the doctor, sitting down with the social worker, and really teasing out what this means can be very helpful. Because often we sign documents without really reading the print. And I see that a lot. And I just ask that people ponder that. Our health may not change, but our way of thinking may change. And so, for example, going back to the medical aid in dying question earlier, I would tell you in 1988, when I left medical school, I was adamantly opposed to any kind of physician-assisted aid in death, euthanasia, pick your word, adamantly opposed to it. And then in my clinical experience, in my life experience, in witnessing the suffering others, yeah, my heart has softened on that. My way of thinking has softened on that. But I would also say medical aid in dying should not become the default because we're not addressing pain and suffering. We can always address pain and suffering. We can always promote care and support from someone who's going through an advanced illness. We can always alleviate suffering, and that does not necessarily translate into medical aid in dying.
Karen, if I can also interject, I think one message that I'd like to be sure our participants hear is that our advanced care plan is our advanced care plan. And even though I'm going to pick on Dr. Unwin because he just shared his experience early in his career. If our provider doesn't agree with our advanced care plan, that is not our individual issue.
Yeah.
The role of our medical team, the role of our surrogate decision maker is to respect what we have documented in our advanced care plan. And that's why it's so important to Nicole and Dr. Unwin's point earlier, when you're naming your surrogate, make certain you're naming someone who is going to assert themselves on our behalf in those consequences or those circumstances in which we may have a medical professional encouraging us to reevaluate that. Again, it's something that sometimes requires us to be assertive. In my way of thinking, and as I've conveyed it to my parents, it's a way that I express my love to them, even in the most critical of circumstances. And I don't want folks to lose sight of that, even if you're in an emergent situation and things may appear to be a little bit intrusive or assertive in asking you to reevaluate your own care plan.
Thank you all. We're coming to one of our, one of our final questions, but I think we just got a new one, so we're going to get to that one in just a second. What can we all do today in the days in the near future to make sure our wishes are honored and respected, and help us understand the importance of trust in this whole process? To me, that's what I'm hearing as an ultimate theme. I'm trusting you with my wishes. I'm trusting that you will respect those, honor those. So help us understand. Oh, Dr. Unwin, you're muted.
I want to layer on a separate topic. I don't want to distract from the primary topic here, but caring for older adults in late life is partly about advanced directives in terms of having those instructions to family about the medical care that we want through our late life experience. And I would also say advanced directives also include advanced planning, housing planning. How are you going to adapt the home when the older adult is becoming disabled? What kind of financial planning are you doing to support yourself and your family in your late life needs, to include things like Medicaid applications that support a person in late life, transportation planning. How are you going to get around if you are disabled or have cognitive impairment? How are you going to live? How are you going to get around if you can't drive and take care of yourself that way? And then lastly, I would say, and again, coming back to the advanced directives issue, but how are we going to live our lives with recreational planning? How are we going to maintain our connections with our communities and our families when it becomes harder as we get older? So I'm going to layer on those other things for all of us to think about for our parents. And then I'll turn back to Nicole and Lisa for advanced directive, more on advanced directives.
Those are wonderful points, Dr. Unwin. I mean, you really could never plan enough. I say that because I had two grandparents, or grandmother, who was meticulous. She had everything planned to what lipstick she wanted to wear at her funeral and what brand. And and love her. I love her spirit so much. And her planning took so much stress off of me and my family when they passed within 3 months of each other in 2021. And I think about other things that were still very stressful. So I couldn't imagine not, knowing, their wishes with their house, what they wanted to do, how if one passed first, who would provide the care, how would they pay for it? Here's the plan. And it was still stressful, I mean, it's because you're grieving, but you're also trying to handle complex situations and make sure that your loved ones are taken care of. And so you can never overplan because you can't plan for everything. And I just think, if there's anything that I would want um, everyone to take away from today, is that really this is just opening up a toolbox of, hey, how can I, talk to my mom or my parents or my grandparents? We've never had that conversation. I've never had that conversation with myself. I really, I want people to start feeling like these are okay things to talk about. Yes, they can be heavy, but it takes off a lot of stress, in the times when it's going to be needed. And I just think that, we can never plan for tomorrow, but I just hope that thoughtful, retrospective, maybe insight to what matters the most to us all can really be put into a document when you're ready to complete it. I think that's what I would want the group to lead with today.
Well, and Nicole, I think that what you're speaking to is preparation. So
Mhm.
being prepared. So you can't plan for everything, but you can be prepared for different situations that you may encounter. Lisa, let me let you add to the conversation.
Sure, I will just share that I am really blessed. I have an 86-year-old father and an 81-year-old mother that are still very, very active and productive. And my dad just this year retired from farming. And as I began to worry personally about not knowing what their wishes were, I began to engage them in conversation, and they were reluctant to engage with me. And I tried different approaches. I talked to wise providers like Dr. Unwin about it. And I began to approach the subject in the context of my sister Susan and I love our parents with an undying love. And I said to my mom and dad, we want to love you through the most vulnerable time in our lives together. And to be able to do that in a way that honors you and gives you the respect that we want to give you, we have to know these things. We don't have to talk about it all today. We can take it in brief chunks of time. And my mom and dad live a couple hours from me. So it became a ritual with my visits home. What are we going to talk about today? This has transpired over a period of years To the point now that when I go home to visit my parents, my mom will say, "Oh, Lisa, I've updated my list and it's in the second drawer of the filing cabinet in the manila file folder with your name on it." And we joke about it now, but I share that to say what can be heavy can be lifting and enlightening at the same time, and can, to Nicole and Dr. Unwin's point, create a deeper bond really among family members in a way you wouldn't expect it. So there's lots that we can do in terms of contemplating and engaging in conversation in little chunks of time and in little chunks of space, and then becoming a little bit more comfortable and mature in the conversation and how it unfolds.
Excellent information from everyone. For those of our attendees who haven't seen the question that popped into our chat, and Dr. Unwin has answered, but I'll just reiterate it for the group. What are the best rules once I have the advance directives done for having them on hand for emergency personnel like ambulance personnel? For instance, if you call 911 or a family member calls 911, what's a good way to make sure they know your wishes? And Dr. Unwin says a large Ziploc bag on the refrigerator that contains the advance directive, the DNR, post form, Medicare card, patient ID, medication list, family contact information, brief medical history, allergy list, list of key items, phone chargers, etc. Boy, you are a prepared man, Dr. Unwin. I feel like I have some homework to do after our webinar.
And I would like to mention the newest version of the Virginia Advance Directive does have space for those things: emergency contacts, medications, allergies. You can list in there, so it's a little bit more informative. So that does encompass a lot of those things that Dr. Unwin said.
Well, I would like to thank all of you, Dr. Unwin, Lisa, Nicole. This has been a wonderful discussion, very enlightening. Lisa, I'm going to turn it over to you for some closing thoughts.
Thanks, Karen. Let me extend my gratitude, Karen, to you, to Dr. Unwin, to Nicole, to Aaron, and all the folks that helped us create this safe space, I think, for us to have conversations. And I hope that the one thing that we can take away from today is that mortality is mortality. We all enter the world through the process of birth. We all leave the world through the process of death. To Nicole's point, sometimes that can come with some circumstances that may feel like we can't control. And that is possible. But what we can control is informing not only ourselves, but others about what matters most to us, and letting those important goals and wishes drive the way we want our end of life plan of care to look. Once we have those thoughts, we have that introspection, we develop what we have in our mind to be what we want. Having that surrogate named is the next important step. And I would argue that if we can't get to the point of a full advanced care plan, naming that surrogate is the most important first step in the process. Then once we have the surrogate named and we've had the conversation and we've executed our advanced care plan, making certain that our medical team of providers know those wishes, have a copy of that document, that is another final step in the process. Doesn't have to be heavy, doesn't have to be serious or fearful, something that we dread. It can very well be something that enlightens and supports and conveys love in a unique and honorable way. And I just appreciate the folks that have joined us today and their attention and their wonderful questions.
Thank you, Lisa. Nicole or Dr. Unwin, do you have any sort of final thoughts?
Are you pointing to me, Doctor?
I'm looking at the chat here. Nicole, do you want to go?
Sorry, yeah. Sorry, I didn't know if you were trying to get off mute or point at me. So, yeah, thank you, Lisa, for those remarks. I mean, I just think that's the right sentiment for today and the perfect way of really wrapping this up. I hope everyone enjoyed today's commentary, and please, if there are questions, you can always refer back to, your providers. There's a lot of information in the chat. Karen, thank you so much today for being here and holding this conversation with us, and just appreciate everyone's time.
You guys
I
have a
would echo
special
that.
place in my
Thank
heart.
you.
Yes, well, thank you all so much. And we have really enjoyed the conversation from you, those of you who are attending this webinar. It's been wonderful to see a lot of feedback, back and forth, engagement, if you will, because that lets us know that this is a topic that's important to you, that's important to our community. So we've, as Nicole mentioned, we've put a lot of resources in our chat. Also, just want to let you know, if you want to learn more about the services, the hospice and home care that Carilion offers, we have several resources there that we can put in the chat for you. So our web address is carillionclinic.org/hospice. And we didn't talk a lot about hospice care because we're focusing on advanced directives. But if you have curiosities about that, you'll find a wealth of information on that website. And then also you can call Carilion Clinic Hospice. We'll put this phone number in the chat, 800-964-9300. And finally, you can visit theconversationproject.org for a lot of free resources and guides to help you get started with advanced care planning. So we thank you for joining us. We hope you'll start having those conversations and hope you enjoy the rest of your day and the rest of your week. Take care.
Thanks.
Thank you.
Thank you, folks.
Thank you.